Welcome to my lecture on eosinophilic CRS. My name is Cecilia Damask. I'm an otolaryngologist in private practice in Orlando, Florida. These are my disclosures for this lecture. I'm excited to talk with you today as part of the pre-work for the Advanced Management of Chronic Rhinosinusitis and the Unified Airway course. This lecture is part of the pre-recorded and on-demand lectures available starting January 22nd through February 5th. The live in-person portion will start January 29th in Dallas, Texas at the Warwick Melrose Hotel. There will be live lectures and panels as well as a hands-on nasal endoscopy session. There will be ample time for you to interact with our world-renowned faculty in a smaller, more intimate setting. Come get all of your questions about CRS with NP and asthma answered. More information about the course can be found at www.allergycrs.org. We hope to see you live in person January 29th. If you can't attend in person, the live portion is also available via live stream from virtually anywhere. Chronic rhinosinusitis, or CRS, is defined as sinonasal inflammation persisting for more than 12 weeks. The diagnosis is based on global consensus and has been consistent for the last 3 decades. Diagnosis requires a combination of subjective and objective findings. Recognized symptoms of CRS include nasal obstruction, congestion, blockage, anterior or posterior mucopurulent nasal drainage, loss or decreased sense of smell, and facial pressure, pain, or fullness. Symptoms alone have a high sensitivity but low specificity, which is why the symptoms must be accompanied by objective evidence of disease. Objective evidence is defined either by radiographic evidence of sinonasal inflammation or by mucopurulent pus, edema, or polyps on examination. Historically, we divided CRS into CRS with and CRS without nasal polyps. This doesn't describe an endotype, nor does it describe a well-defined clinical phenotype. Furthermore, it doesn't help with a treatment paradigm. These phenotypic subgroups are well-recognized clinical entities, just like allergic rhinofungal sinusitis, AERD, and cystic fibrosis are. Our understanding of classification by endotypes emerging, with some research suggesting 10 or more inflammatory subtypes may exist. While the global definition of CRS remains stable, it's important to recognize the significant variability that's present within this condition. The European position paper on rhinosinusitis and nasal polyps group is a task force of the European Academy of Allergy and Clinical Immunology. EPOS 2020 is an update of similar evidence-based position papers published previously. The core objective of EPOS 2020 guideline is to provide revised, up-to-date, and clear evidence-based recommendations in ARS as well as CRS. A new classification of CRS into primary and secondary CRS and further division into localized and diffuse disease based on anatomic distribution was proposed by EPOS 2020. This new classification system is based on endotype. It moves away from the previous simple classification of polyps and non-polyps. There are 3 simple levels to describe CRS. The first level of the classification is primary versus secondary. Primary CRS is a primary disorder of the respiratory system, not part of a broader condition. The second level of classification is localized versus diffuse. This breaks down to anatomically, where is it distributed? Then the third level of classification is the endotype dominance. It's broken down into T2 versus non-T2. We know that CRS is a heterogeneous chronic inflammatory condition of the paranasal sinuses and nasal passage. Inflammation in CRS is also heterogeneous and is mainly characterized by type 2 inflammation, but subsets of patients show type 1 and type 3 inflammation as well. The diagram on the left shows all three types of inflammation seen in CRS, and the diagram on the right focuses on T2 inflammation. We're going to focus our discussion in this pre-recorded session on T2 inflammation. In Western countries, CRS with NP is well known to be characterized by type 2 inflammation with pronounced eosinophilia and the presence of high levels of T2 cytokines like IL-5 and IL-13. Also, T2 inflammation is associated with the presence of nasal polyps and asthma. Stevens et al. Examined if certain CRS inflammatory endotypes were associated with specific clinical presentations. They used mRNA and protein data from over 250 CRS patients. Among CRS with NP patients, the overall frequency of any T1, T2, or T3 inflammation was 17, 87, and 18% respectively. They examined whether specific clinical characteristics were associated with a particular inflammatory endotype. Among all CRS patients, those with the T2 endotype were significantly more likely to have nasal polyps, asthma, smell loss, and allergic mucin. They were also less likely to report rhinorrhea, cough, and pus. Stevens et al. Also performed a multivariate logistic regression analysis and found that smell loss was associated with T2 endotype, and intraoperative pus was associated with a T3 endotype. And this was controlling for things like age, sex, nasal polyp status, atopy, and asthma. In addition, headache was negatively associated with a T1 endotype. They noted that complaints of smell loss were significantly higher in eosinophilic CRS, and that expression of an eosinophil marker, CLC, in the superior turbinate correlated with olfactory defect in CRS, suggesting that T2 inflammation promotes smell loss in CRS. However, we know that smell loss is well known to be associated just with the presence of nasal polyps. And so therefore, it wasn't clear whether the T2 inflammation was just a marker of nasal polyps or whether the T2 inflammation was instead more directly associated with smell loss. In this study by Stevens et al., they found that T2 inflammation was also associated with smell loss in CRS without nasal polyps. Furthermore, smell loss was still associated with the T2 endotype while controlling for asthma and nasal polyp status. These results suggest that the symptoms of smell loss may be directly induced by T2 inflammation. There has been a growing appreciation that establishment of endotype, which initially involved classification by histologic features like the presence of neutrophilia, eosinophilia, fibrosis, etc., can provide insight into treatment response or pathobiology. Recent efforts seek to define CRS endotypes based on specific molecular biomarkers or mechanisms. Endotypes do have strong associations with phenotypes and histologic findings. Endotypic disease classification, however, is challenging. And this is because considerable amount of tissue is required, pathologist interpretations are variable, endotype assays are not readily accessible, and the results can be influenced by treatment. Nonetheless, There is a shift of interest towards the molecular pathways that underlie endotypes that drive inflammation, remodeling, and clinical phenotype. In conjunction with new, specific, and powerful interventions targeting molecular pathways, study of endotype holds great promise for us and for our patients with CRS with NP. Studies based on histology quantified the numbers of eosinophils, mast cells, and neutrophils. In the West, CRS with NP patients had higher numbers of eosinophils and mast cells, while those without polyps expressed relatively higher levels of neutrophils. Heterogeneity of histology made it clear that there were multiple overlapping processes. Specifically, many CRS with NP patients were associated with both eosinophilic and neutrophilic infiltrates. Furthermore, a subset of CRS without polyp patients exhibited elevated eosinophil counts. Histologic phenotyping to distinguish endotypes is only as good as the specificity of inflammatory cell counts or tissue structural changes evaluated. Early molecular studies indicated that IL-5 and IgE are important biomarkers in eosinophilic CRS, while IL-8 is found in neutrophilic CRS. We're going to move on now, and we're going to specifically discuss eosinophilic airway inflammation. Let's start off by defining and discussing some patient characteristics seen with eosinophilic chronic rhinosinusitis, or ECRS. ECRS is an inflammatory condition due to T2 responses that are driven by eosinophilic inflammation. These patients tend to be older, about 30 to 50 at onset, compared to those who have early onset allergic disease, usually less than 20 years old. Another common presenting pathway is an adult patient who said they were completely well until they had a viral event or a cold, and then they never recovered. Although some of these adult onset ECRS patients may have had a history of allergic disease in their childhood, they often report that it was quiet for many years, they had very few symptoms in their early adult life, and then it came back in their 30s to 50s. Smell loss is a major feature early in the disease process for ECRS patients. Acute exacerbations, likely due to secondary obstructive or infective phenomenon, are also common. And these adult onset ECRS patients often seek antibiotics on multiple different occasions. Corticosteroid responsive smell or olfactory recovery is another common feature. Patients almost always report a history of asthma that started around the same time as the onset of their upper airway symptoms. Corticosteroid responsiveness is a major feature of ECRS. These patients often report a dramatic benefit, usually within days of starting a steroid, and smell often returns very quickly. Moving on to endoscopy findings associated with ECRS. On endoscopy, ECRS patients will have evidence of thick, tenacious eosinophilic mucin. They may also have polypoid edema or many small polyps or true large polyps in their nasal cavity. Often during surgery, mucinous casts are found, or chewing gum-like mucin is noted along with diffusely thickened mucosa throughout the sinus cavities. Next, we're going to discuss radiology findings associated with ECRS. ECRS patients often have complete pan-sinus opacification with very high Lund-Mackay scores. They may also have evidence of secondary obstruction present on CT imaging. Neo-osteogenesis changes are also often seen as well. Lastly, let's discuss the histopathology seen in ECRS. ECRS patients will have tissue eosinophilia. Currently, there is no accepted definition of how many eosinophils per high-power field would be considered true tissue eosinophilia in CRS. Some suggest greater than 10 EOs per high-power field. Many patients will have sinus biopsies with over 100 eosinophils per high-power field in ECRS. Another challenge is that pathologists frequently don't count the number of eosinophils per high-powered field. A recent systematic review by McHugh et al. Demonstrated that a cutoff of 55 eosinophils per high-power field predicts the likelihood of recurrence following surgical intervention. What about systemic predictors of eosinophilic chronic rhinosinusitis? Well, Ho et al. Investigated the association between biomarkers and ECRS in order to assess the predictors of ECRS. It was a cross-sectional study of 345 patients with CRS undergoing endoscopic sinus surgery. In this study, ECRS was defined by histopathologic assessment showing more than 10 eosinophils per high-power field on sinus mucosa biopsy. Blood tests were performed preoperatively and assessed for CBC with differential. Comparisons between ECRS and non-ECRS patients were performed. Peripheral eosinophils were significantly elevated in ECRS, about 420 on average versus 170 in non-ECRS. Receiver operating characteristic curve analysis predicted high tissue eosinophilia at blood eosinophil levels above 240. Blood eosinophils are a moderate surrogate predictor of ECRS. A blood eosinophil count of more than 240 predicts ECRS tissue eosinophilia of more than 10 eosinophils per high power field. This group out of Australia further suggests that a blood eosinophil count of more than 450 is associated with need for long-term systemic therapy following endoscopic sinus surgery. There remains limited data surrounding the prognostic use of biomarkers in ECRS. However, peripheral eosinophilia best predicts the eosinophilic density that best predicts the ERS phenotype. In addition, it is also prognostic of the need for more intensive therapy. H&E stained sinus mucosa still remains the most reliable tissue for assessment. Since the late 1990s in Japan, there has been a noted increase in recurrence of nasal polyps following surgery. Traditionally, nasal polyps in Japan were noted to be neutrophilic dominant. These patients who had recurrent disease, however, were noted to have anosmia as their main symptom, also with viscous nasal drainage and complaints of nasal obstruction. They also frequently had comorbid asthma. Their histopathology also revealed an eosinophil dominant infiltration. In order to establish guidelines for the diagnosis of ECRS, a multi-center, large-scale epidemiologic study entitled the Japanese Epidemiologic Survey of Refractory Eosinophilic Rhinosinusitis Study, or JESREC, study was initiated in 2010. Eventually, they proposed diagnostic criteria for ECRS. A JESREC score is determined as the sum of scores of 4 items seen here on this table. Bilateral involvement, presence of nasal polyps, CT changes, and peripheral eosinophil count. A suggested diagnosis of ECRS is made if the JESREC score is 11 points or higher, with a final definitive diagnosis of ECRS made histologically when the mean number of eosinophils noted on high power field was greater than 70. Chronic rhinosinusitis is a complex, heterogeneous disease with different phenotypes and endotypes. There are treatments for the different phenotypes of CRS based upon the presumed underlying cause of their inflammatory process. Research continues to shed more light on different endotypes and phenotypes of airway inflammation. Understanding these different phenotypes and their etiologies will allow for further management of these difficult to treat patients. I look forward to seeing you live in Dallas on January 29th to further discuss CRS with NP and the Unified Airway. I hope to see you there.